think we can kind of get started. 7:30, I think there is something after the meeting here, so we're just going to get started. So, good morning, everyone. Welcome, and thank you for joining us this morning. I'm Larissa Furtado. I am a molecular pathologist at St. Jude Children's Research Hospital, and I'm here today with Dr. Yen Lu, who is my colleague at St. Jude. She is a hematopathologist and a molecular pathologist. And today we'll be covering some of the advanced molecular technology applications in in pathology diagnosis. We are going to go over whole transcriptome sequencing, gene expression profiling, copy number alteration assessment, MRD monitoring, and DNA methylation profiling. So quite a lot to cover. And I'll start with whole transcriptome sequencing. So whole transcriptome sequencing refers to the analysis of all transcribed genes in the genome. And most of the whole transcriptome sequencing protocols to date have been developed on short-read sequencing, which is the most it's the most common method currently used in clinical laboratories. And there are several variations of the wet bench protocol, but at a high level, the DNA fragments are reverse transcribed into cDNA, and libraries are generated. And during the library preparation, individual barcode sequences are added to the DNA samples to allow for multiple patient samples to be sequenced together in the same reaction. And the result is sequencing data for all transcribed genes. But although short-read sequencing has been the most prevalent testing approach, long-read sequencing methods are also available and are starting to make their way into clinical laboratories as well. Each of these technologies have specific advantages and limitations, but overall, short-read sequencing is quite robust and provides the highest throughput in terms of number of reads per reaction, which can be particularly relevant for some applications, such as the detection of fusions when the genes have low level of expression, such as ETV6 RUNX1 in leukemias, or if you're looking at gene expression profiling analysis as well. And short-read sequencing can also circumvent some issues related to specimen integrity because it does not require long fragments of RNA to work on. So it can work relatively well, even with degraded RNA obtained from FFPE samples. In contrast, long-read sequencing generally has lower throughput and is not very suitable for sequencing of degraded RNA molecules, but some protocols allow for direct RNA sequencing, which is sequencing of the RNA directly without having to convert that into cDNA or do any PCR amplification during library preparation, which actually enables the epigenetic information to be preserved, so you can obtain methylation status information from that same reaction. And whole transcriptome sequencing is a very versatile analysis method that allows for comprehensive detection of gene fusions and complex structural variations, but also can provide information about mutation status, copy number variant analysis, and also allow for quantification of gene expression, like Dr. Lu will talk about when she gives some examples of emerging applications in leukemia testing. And so the whole transcriptome sequencing analysis can capture the full spectrum of cancer-associated genomic alterations, but currently it's mostly used in clinical laboratories for the detection of gene fusions. But to put in perspective, whole transcriptome sequencing is one of the several approaches that are available for gene fusion detection. And fusion assessment by next-generation sequencing can be performed at the DNA or RNA level using targeted methods or comprehensive approaches such as whole genome and whole transcriptome sequencing. And currently, clinical sequencing analysis for fusion detection is mostly done using RNA-based targeted gene panels, although commercial and academic clinical laboratories are offering whole transcriptome sequencing for fusion detection more often now than it used to be past years. And because sequencing strategies for fusion detection are not necessarily equivalent, when you select a test, it's really important to consider the scope, the analytic capabilities, and the limitations of all these different methodologies available, so you can determine if that particular test is suitable to address a particular clinical question. So RNA-based tests tend to be a better strategy than DNA-based methods for fusion testing because most of the fusion breakpoints occur within the intron of each partner gene, and the fusion breakpoints can occur pretty much anywhere in the introns. So in order to detect gene fusion using a DNA-based assay, it's necessary to include many probes tiling intronic sequences where the potential breakpoints can occur, and to sequence these regions at a considerably high depth to achieve sufficient coverage and analytic sensitivity for the reliable call of the gene fusion breakpoint, which can get quite expensive. In addition, introns can be tricky to sequence due to the presence of repetitive elements and low complexity sequences that either preclude the design of probes to cover certain regions or that result in a high off-target rate, which increases the cost and decreases the efficiency of sequencing. And this is an example, a classic one actually, of intron 32 of ROS1, in which you notice that due to a repetitive sequence in high homology with other genomic regions, there is an intronic segment which could not be covered by the probes. I think it's hard I don't think you can see my arrow in the... But so you can actually, you see that the probes are those blue squares that are underneath the intronic regions, and there is an area in which the coverage is very, very low and cannot be covered because of the biological characteristics of these samples. In contrast, RNA sequencing does not require the specific knowledge of intronic breakpoints because testing is performed in spliced mRNA that contains the exonic sequences of the fusion genes. And in addition, when comparing DNA and RNA-based strategies, RNA-based tests can detect the transcript expression, which can be quite helpful to support that the fusion in question is functional, and can directly assess the actual chimeric gene sequences. And the main RNA-based target approach for fusion detection include amplicon-based assay and anchored multiplex PCR. So amplicon-based sequencing uses PCR to select a subset of genes of interest for sequencing, analogous to multiplex RT-PCR, which Dr. Lu is going to go in more detail in her section of the talk. While in anchored PCR, the primers are designed to target one of the partner genes and will amplify across the exonic regions of the fusion, allowing for detection even if only one of the partner genes is targeted by the assay. So the scope of the amplicon-based test tends to be much more limited when compared to anchored multiplex PCR panels because amplicon tests will only detect gene rearrangements and fusions that are specifically targeted by the primers included in the assay, whereas anchored multiplex PCR system enables the detection of a targeted fusion with knowledge of only one of the gene partners. So amplicon-based sequencing would be a good testing strategy in settings where both gene translocation partners are recurrent and the rearrangement breakpoints are constant, such as in the example here, in which the tumor is likely a Ewing sarcoma, and the test targets represented on the table in the right covers the most common genes that can be fused in Ewing sarcoma, as well as the breakpoints. However, if you have in cases that have unusual or unexpected findings that are likely to have alternate gene partners, amplicon may not be the best strategy. So this is an example of a case in which, based on histology, the tumor looks like an infantile fibrosarcoma, which is mostly driven by an ETV6 and TRAC3 fusion. However, the FISH for ETV6 was negative for rearrangement, and we know that there are other partners of NTRK3, such as EML4, that can be involved in the fusion. When we're choosing an amplicon-based test, it's important not only to look at the list of genes, but also to look at the way that these genes are arranged, because you'll see that the test with the list on the left covers both EML4 and NTRK3, but what they are actually looking for is for very specific fusions in ETV6 and TRK and EML4-ALK. So this particular test probably would not be helpful in this case. And in such cases, the anchored multiplex PCR-based sequencing would be a better testing strategy, and because you only need to know one of the partners, But this would be a great opportunity really for whole transcriptome sequencing, because you don't really have to select your genes. You're looking at all the genes that are transcribed in the genome. And the comprehensive nature of whole transcriptome sequencing is an advantage over targeted panels, particularly in tumors that have heterogeneous biology, such as in this example, in which we have this spindle cell neoplasm in a young kid that expresses both CD34 and S100. And those findings are quite characteristic from this provisional entity in WHO, which is the NTRK rearranged spindle cell neoplasms, which they have microscopic and immunohistochemical characteristics in common, and they are most likely driven by NTRK1 fusions, but now is known that these tumors can actually be driven by different kinase fusions, including ALK, BRAF, RAF, and others that have been described. So in that case, we did whole transcriptome sequencing, and we detect a fusion involving LTK, which is a kinase gene that has high homology with ALK and also can activate the RAS MAPPK pathway. And that had actually been recently described as a fusion detected in a tumor with similar characteristics as the one that I had described. And even though we have a very customized targeted panel in our institution as well that was designed to target pediatric solid and brain tumors that you can see on the right, and it's based on anchor multiplex PCR. If we had used this targeted panel, we wouldn't be able to detect that particular fusion because neither LTK nor MYH9 are actually targeted by the panel. So whole transcriptome sequencing can be quite helpful when you have situations in which you're testing something that can be more unusual like that. So I think for this part, I wanted to make sure that you understand that the NGS testing for fusion detection are not necessarily equivalent, and understanding the characteristics, capabilities, and limitations of different methodologies is really important. And if you get a negative test result in a context that's suspicious for a gene-fused tumor, you should not stop your workup, and you should potentially consider something more comprehensive like whole transcriptome sequencing. So good indications for whole transcriptome sequencing would include when you have a negative test result in a situation in which your likelihood of having a positive result is very high. To characterize non-canonical fusion partners, which may not be covered by your targeted gene testing approaches. If you have an indeterminate or an atypical test result, or if you are not exactly sure what you're looking at, the good thing about whole transcriptome sequencing is that you don't have to select a gene to test for, you're looking at the entire transcriptome. So here is a good example where whole transcriptome sequencing was very helpful. This is a brain tumor that, based on the histology and the immunohistochemical findings with positivity of CD99 and WT1, was very suspicious for a CIC rearranged sarcoma. This patient had come from an outside institution and had done a targeted fusion panel testing, which was negative for any fusion. So the importance of detecting CIC rearranged sarcomas, even though this is a very rare tumor that occurs particularly in the pediatric population, is because this is an aggressive tumor that does not respond well to the therapies that are normally given to Ewing sarcoma tumors, and they can have a very overlapping histology with other round cell sarcomas. And detecting a rearrangement of CIC is the only way to really sometimes actually to get to that diagnosis, even if you have a high suspicion that that's the diagnosis. And it's very often we use FISH for that approach, but here you notice that the FISH from that case came back negative. So we are using a break-apart strategy in which you have two probes that are labeled with two different fluorophores flanking the CIC gene. So the expectation is that if there is a rearrangement, those fusion signals are going to break apart, they're going to split and be separate from each other. And in this case, you see that the green and the red signal are actually juxtaposed. But you see that there is only one signal consistently in every tumor cell, which suggests that there is a heterozygous deletion. So here you notice that we did some array testing, which was able to explain the reason why that was the case, and that's because there was a deletion involving 19q where the CIC locus is present, so that's why there isn't a copy of CIC. And the other possibility for that rearrangement not being present is because there are some tumors, some gene partners of CIC that are very closely located, so the probe doesn't have enough resolution to break apart. But just with these tests, you wouldn't be able to come out with the diagnosis of CIC definitively, and having a negative testing panel, that becomes quite difficult, right? So whole transcriptome sequencing was a method that was helpful in this case and was able to detect a CIC-Lutex fusion. And sometimes targeted panels don't detect fusions either because the gene is not present, but also because the breakpoints may be unusual, and the probes, which in this case are listed at those very small blue squares in the bottom, they don't actually cover the breakpoint, so you ended up missing it. And whole transcriptome sequencing doesn't have that problem because it's looking at everything. Whole transcriptome sequencing is also very helpful to work up tumors that are genomically complex, such as this particular case that was very inspecific from a immunohistochemical standpoint. And a panel from outside that was done using targeted sequencing detected two fusions, one of which involved SMARCA4, which is associated with rhabdoid tumors. So the oncologists were very concerned, and they wanted to start therapy for rhabdoid tumor. But then what gave pause was the fact that the BRG1 expression was positive, and BRG1 is the protein that's expressed, that's encoded by SMARCA4, and you would expect the expression of BRG1 to be lost if you have a structural alteration of SMARCA4. And the other thing that called a lot my attention was the fact that the alterations were kind of almost juxtaposed to each other. So the suspicion is that those could actually be passenger fusion events and not real fusions. So whole transcriptome sequencing was performed, and you notice that a lot of alterations in chromosome 19 were detected very close to each other, including one of the fusions that they had detected outside, which turned out to be just a passenger fusion. But we were able to detect a driver fusion involving the Lutex gene that included a functional domain of the gene, but we also were able to use the expression obtained for whole transcriptome sequencing in order to demonstrate that that fusion was functional because the Lutex expression was very high. The suspicion based on the whole transcriptome sequencing was that maybe that complex alteration was caused by chromotripsis, for example, and the chromosome array that was done, the microarray, show, as you can see, chromosome 19 completely shattered. And the chromotripsis is this very catastrophic event in which the chromosome just just breaks. And then it, in a very disorganized manner, it rejoins its pieces. And sometimes that can lead to functional fusions. Clearly, you're going to tell me that detecting a Lutex fusion is not that important because, we don't have like any targeted treatment for that. But the fact that you are able to understand the biology, the mechanisms, and determine that SMARCA4 was not the driver changed the fact that we're not doing therapy for rhabdoid. So that's helpful with NGS. So NGS is good for some of the inconclusive results, and it's also important to understand that there are fusions that can be passenger only, and not everything is actionable. And another good indication for whole transcriptome sequencing testing is to detect promoter or enhancer hijacking. So this is a mechanism that instead of having a fusion that joins two different exons to activate a certain pathway, the promoter of a gene, which is demonstrated in blue, gets there is a chromosomal translocation, and that promoter gets into close proximity to the promoter of another gene and leads to activation of the gene that's downstream. And that's a mechanism that's commonly a driver of the FOXR2 rearranged brain tumors. And it's also a mechanism that can lead to the activation of PLAG1 in lipoblastoma. So if your targeted panel is not covering the region of the genome, you're going to miss. Whole transcriptome sequencing can detect and provide the support of the expression of the gene, so then it's functional. So just to finalize this section about some considerations, because whole transcriptome sequencing is very helpful, but it's very important to take into account the technical requirements of the test and the limitations of the assay, as for every test that we do in the clinical laboratory. So the pre-analytic factors can be very important, and beside the sample quality and some other sequencing parameters, tumor cell content is really important for the sensitivity of the test. And for example, in this case, the tumor had the appearance of an angiomatoid fibrohistiocytoma, which is driven by fusions involving either EWSR1 or FUS, but we did FISH and whole transcriptome sequencing, and both of them were negative. And when you look at the actual specimen, because the likelihood was so high, it was really, puzzling, you notice that there was a relatively low tumor cell content in the tested area because the tumor is inflammatory. So likely the result was a false negative due to that, like contamination of the non-neoplastic tissue. And then we selected a different area that was more tumor-rich, and you were able to detect the driver fusion, in this case, between EWSR1 and ATF1. So whole transcriptome sequencing is helpful, can improve the diagnostic yield, but as for every other test, it's really important to understand, the technical requirements, limitations, and also, so then when you get your result, it's easier to interpret in light of the entire test and not the result in isolation. So now I will pass to Dr. Lu to go over gene expression profiling.
Well, thank you, Larissa. So then after Dr. Furtado's very comprehensive whole transcriptome analysis talk, we're going to switch gear and then talk about gene expression profile a little bit. And this is actually also an important application for whole transcriptome analysis. So that we're going to look at a couple of samples. So then the first example we have, this is a case. Our patient's a 30-year-old female presented with cough. So after a while, like the symptom didn't improve, so then her primary ordered a chest X-ray. Unfortunately, we saw a mediastinal mass. So then the biopsy of the mediastinal mass actually was shown in the middle section. So you can see there were a diffuse infiltrate of a median large-sized lymphoid cells, and then they are all uniformly positive for CD20. So at this point, the main differential diagnosis for us will be a primary mediastinal thymic large B-cell lymphoma versus diffuse large B-cell lymphoma. Primary mediastinal large B-cell lymphoma is an aggressive large B-cell lymphoma of thymic B-cell origin with distinct clinical, immunophenotypic, and then genetic features. So why is it even important to distinguish these two? Because the PMBL and the diffuse large B-cell lymphoma may actually be treated somewhat differently. And that was the reason why it is important to differentiate these two entities. So through genetic profiling of a primary mediastinal large B-cell lymphoma, people actually find that like gene expression profile of a primary mediastinal large B-cell lymphoma shows some similarities to that of classical Hodgkin lymphoma, nodular sclerosis, and it was different from diffuse large B-cell lymphoma. So that makes us feel like, hey, if we can identify a distinct gene expression profile in PMBL, that can help us when the cases are difficult and we cannot make the distinction. However, like the gene expression profile was not widely used due to issues like regarding the standardization, statistics, and actually validation. However, in recent years, that the development of simpler and faster methods that can be used on FFPE actually really facilitate the application of using gene expression profile in a clinical setting like our daily practice. So here, I'm actually showing two examples of how we can potentially use a gene expression profile in a clinical setting. So I was actually trying to sell you guys this idea that distinct gene expression profile in primary mediastinal large B-cell lymphoma can be used. And then they can actually be detected by multiple different methods. And here I'm actually just showing like two of the examples. On the left-hand side, that's NanoString. And on the right-hand side, it's called the MLPA. So what is NanoString? NanoString is actually a gene expression profiling assay based on the hybridization intensity with specific probes. So how does NanoString work? So this, of course, is an oversimplified kind of like figure, but you get an idea. Whenever we have a specific target, there will be two different probes. On the left-hand side, it's called a biotinated capture probe. On the right-hand side, it's called a fluorescence, like the reporter probe. And then the reporter probe will be conjugated with a specific fluorochrome barcode that's only specific to that target. So in this picture, you can see the yellow, like green, then like the blue, red, and green. So then that will be a specific barcode for target A. So then this target and the probe like complex can be isolated actually when we use the striptidine coded service. And after we pull everything down, we took an image. And then by actually counting the specific fluorescence signal, we can actually evaluate like the expression of the gene. So that's actually more or less how NanoString works. So then you can actually imagine that if you had multiple numbers of a certain barcode, that's actually how we enumerate it. So in this specific paper that was published in Blood in 2018, so then the group from Arizona actually proved that if you use a specific combination of 58 genes, you can actually distinguish a primary mediastinal large B-cell lymphoma from diffuse large B-cell lymphoma. So how about the right-hand side, MLPA? MLPA can also be used as a gene expression profile. So then it is actually based on the reverse transcriptase multiplex ligation-dependent probe amplification, MLPA. So how does it work? So actually, this again is an oversimplified kind of version of how it really works. But if you look at it, it also requires two different probes. This time, the name is easier, left probe and then the right probe. The left probe actually had a forward primer, and the right probe have the reverse primer. But the right probe also got something called stuffer sequence. So then the stuffer sequence actually are of different lengths, depending on the target that you are looking at. So only when the left probe sit right next to the right probe, they can be ligate together. So as you can see, that's the middle part of the plot. So then when actually you have different probes annealed to different targets, you generate different length, like DNA template for it to amplify. So then actually when we do the PCR reaction, so then just by counting the product of different length, you will be able to enumerate actually the gene expression of different targets. So that's more or less how MLPA work. So in this paper that was published in JMD in 2017, they demonstrate that if you use this 21 gene like a panel, it can actually help differentiate PNBCL from like a DLBCL. So then this is actually just two of the things that potentially can be used to evaluate gene expression profile and help us to make a HEMPAS diagnosis. So we have another case actually to kind of keep looking at this issue. This time, our patient, unfortunately, is a 5-year-old boy presented with anemia, thrombocytopenia, and circulating blast. So as you can see that when they did a bone marrow, and then the marrow is effaced by numerous blasts. That's what you can see actually in the middle part of the slide. The flow is done. As you can see, it was positive for immature markers, CD34. It is strongly positive for CD19. It is strongly positive for CD10. That's very bright. And as you all know, that's actually a very common aberrancy for BALL. And the blasts were negative for NPO, and it was also negative for surface and cytoplasmic CD3. So we rendered a diagnosis of a B lymphoblastic leukemia lymphoma. So good old days, we stopped there, but it's no longer true. So you can see, actually, it's a really exciting time to be a hematopathologist. Now we don't even just have one classification, we got two. So on the left is the ICC, International Consensus Classification, and on the right is the 5th edition WHO. And this is by no means like a very impressive list of the BALL classification. But fortunately, we still have some of our old friends, like we can even make the diagnosis through cytogenetics, like FISH for ETV6-ROS1 and TCF3-PBX1. So they are both recognized actually by the classifications. So of course we can do FISH, but today since we are talking about molecular, we're gonna talk about some of the molecular assays that we can use to detect those fusions. So this is something that we heard a lot actually from even when I was a fellow, like the RT-PCR. So the way that RT-PCR was really done is that we have an RNA pool that we extracted from the sample, and then we use either oligo-DT or random hexamer primer to actually generate the cDNA template for the follow-up and the subsequent PCR reaction. There are actually main two platforms for RT-PCR. On the top, you can see called the CyberGrain, and then the lower part is called the Tagman. Most of the labs probably will be using Tagman, but I just thought that would be interesting to tell people that what are out there. So the CyberGrain is actually just a nucleotide, nucleic acid-like dye. So it preferentially would like to bind to double-stranded DNA. So as you can see, when there was no double-strand DNA, that they are just floating around in the reaction. But once the PCR reaction started, once you start to have the double-stranded DNA products, like all this bond die will start to be incorporated into the double-stranded DNA. So actually you can imagine if we evaluate like the intensity of the fluorescence, that would be roughly proportional to the amount of the product that you have. So cybergreen itself is not specific. It can bind to any double-strand DNA. So then you actually rely on the primer being specific and give you a specific double-stranded product. Tagment, how does it work? So tagment actually is a sequence specific. Usually the tagment probe will be composed of two parts. The 5' end is a fluorescence, and then the 3' end is a quencher. So when the fluorescence is very close to the quencher, it stops fluorescing. So you're not gonna see anything. And it just sits actually where like the sequence is. But when the PCR reaction started, the polymerase started progressing from the 5' end to the 3' end. When it actually encounters the probe, it would actually kind of degrade it. So then now the fluorescence got released and freed from the quencher, and then that's when you start seeing the fluorescence. So again, with that mechanism, the intensity of the fluorescence is roughly proportional to your product. And then those are actually the ways that we usually use in a clinical lab to identify the RT-PCR product. So if we design the primers probe correctly, we can actually use them to identify gene expression or actually fusions, like our old friends like BCR-ABL, ETV6-RUNS1, and all these fusions. So that's actually definitely one way that we can use to identify them. And then the turnaround time is not bad, so that's something we can potentially use. However, we're gonna go deeper into this BAL classification. Now we're looking at Philadelphia like BALL. So this is also kind of our old friend. It was first recognized in the 4th edition WHO classification back in 2016. So it was actually considered as an established entity now by both classifications. So as you all know, Philadelphia chromosome-like BALL. Philadelphia-like BAL is a high-risk subset with a gene expression profile that overlaps with a Philadelphia positive BALL. Sometimes it was also called BCR-ABL1 like BALL, like what you can see actually in the current classification. So why is this so important? Because it could actually have various genomic alterations that can activate kinase or signaling pathway that can potentially be targeted. And then these alterations can be grouped into major groups. So then we can kind of roughly look at it this way. They can be grouped into ABL class fusions or JAK-STAT activating kind of a group. So in the ABL group, like you are seeing ABL1, ABL2, CSF1R, and the PDGFR beta. And then in the JAK-STAT pathway activating part, you are seeing the CRLF2, JAK2, and the EPO-R. So again, the reason why it's so important is because we have inhibitors for those. So then potentially, if in your institution this is available, the kid can potentially be treated with all these inhibitors, and then that's why it has a treatment implication. So how does COG group actually identify this Philadelphia-like BAL cases? So the way that they do it is actually with a microfluidic card, and then which can hold up to 384 simultaneous real-time PCR reactions. And that would be something like look like on the left. So it is actually a microfluidic card. You can load 8 samples at the same time. Every single well is preloaded with a gene expression assay. So then when you load the sample, you can actually literally conduct 384 reactions. So that actually really increased the number of, real-time PCR assays that can be done in a given time. And so in the first paper that actually recognized Philadelphia like BALL, the data was actually through microarray. They look at the gene expression profile derived from microarray. So with that data, actually the COG group developed an 8-gene quantitative assay, and that's what they use for this microfluidic card. So then these 8 genes include, as you can see in the bottom, the J-chain and actually SPATS2L, CA6, and also the CRLF2 and the ADGRF1 and the BMPR1B. And then actually they come up with an integrated score between 0 and 1. So like if you have a predictive score equal or larger than 0.5, actually that would be considered as a Philadelphia-like for the COG trial. So that was actually for Philadelphia-like BALL. So now we are actually gonna see a really new entity that's actually called BAL with ETV6-RUNX1-like features. And then like this entity is considered as an established entity by the 5th edition WHO, but it's considered as a provisional entity for the ICC. So what is this entity? B lymphoblastic leukemia lymphoma with ETV6-RUNX1-like features are cases that demonstrate gene expression profile that overlaps significantly with BALL with ETV6-RUNX1 rearrangement, but do not have the ETV6-RUNX1 rearrangement. And so these cases usually would have an immunophenotype that's very similar to what we see in the ETV6-RUNX1 case. So it would be 27 positive, CD44 deemed to negative. It's actually rare and mostly in children, so then we probably would see more SNG like than other people. And the reason why it is important is actually preliminary studies from multiple groups show that the prognosis of this kid may not be as good as the ones that have ETV6-RUNX1 rearrangement. So fusions or copy number alterations in this so-called ETS family genes, including ETV6, FOS, and also IKZF1, are very commonly seen actually in these cases. So there was actually one study that actually they show genetic alterations affecting both ETV6 and IKZF1 were identified in 5 out of 5 cases that actually have material for RNA sequencing and SNP array. So that's just something that you can potentially see when you don't have a gene expression profile, but we're doing other genetic categorization. So some cases in this group may potentially even have germline ETV6 alteration. So just like what Dr. Furtado said that, a whole transcriptome analysis really enable like the evaluation of the whole transcriptome. So then the transcriptome analysis allow us to look at the dynamic changes in gene expression. And RNA-seq not only identify, this is like a unique transcript, like what Dr. Furtado has shown, like the alternative splicing or actually novel fusions, but it can also give us information about single nucleotide polymorphism. And then it has been increasingly used actually for biomarker discovery and identify molecular signature, like what we just see. We are identifying cases right now based on the gene expression profiling. So this is actually sort of a demonstration of what we do at St. Jude and what can potentially be used to identify those cases at our institution. So what you are seeing here is a t-SNE plot. It is actually based on the whole transcriptome analysis data. So we so far hopefully I convinced everyone that gene expression profile help identify some new genetic subgroups. We already talked about Philadelphia-like. And we are talking about this new group about ETV6-RUNX1-like. So then what actually you are seeing in the plot, every single dot represent a sample. And all of them are BALL sample in this figure. So and then they are all of different colors. So luckily, you can really see a pattern that based on the gene expression profile, cases with similar genetic alterations cluster together. So if you look at your far left, that's the KMT2A, and then you can see the ETV6-RUNX1, the circle one, was actually the right lower corner, and then they also cluster together. But I want to bring your attention to some of the cases that were actually of different color. So there are cases that with a gene expression profile similar to the ones with ETV6-RUNX1, but do not have the ETV6-RUNX1 rearrangement. Those are the cases that we will consider as ETV6-RUNX1-like. And then through this method, you can also see the KMT2A-like and then the ZNF3A4-like. I know this is actually really becoming a kind of a translational and a kind of emergent entities at this point, but you can see how those entities were actually identified and then mentioned in the new classification. So even though currently whole transcriptome analysis was really the way people used to actually identify all these cases, but I guess like we can imagine, just like a Philadelphia, like a BALL, maybe down the road, there will be a more targeted and focused kind of assay that can help us identify these cases through some other methods other than whole transcriptome analysis. So that's actually something that I would like to kind of mention about gene expression profiling, utility actually in daily practice. So this is actually a T-SNE plot for AML, and I know many of you are very worried I'm gonna go through all these groups, but I promise Dr. Furtado I won't. So that's not gonna happen. But this is really just to show everyone that actually the gene expression profile can be used in many different kind of like disease entities and can potentially help identify new disease subgroups. And then if they actually have a clinical implication, treatment implication, then they may deserve us to give them a unique kind of name or diagnosis. So this is just something kind of sort of a cooking or down the road that we may be able to see. So this is a summary slide that, of course, again, this is an oversimplified kind of summary, but we try to list a couple of methods you can potentially use when you consider doing gene expression profiling, like of your case. So the first one is definitely our old friend IHC. We can get it within hours or days, but you need to know what you want to look at. And then you use one slide, you need to recognize the tumor, which we all will be able to do. And then, so then we are talking about hundreds of dollars. And RNA-seq and then targeted panel gene expression profile, like what we have seen the MLPA, or like something like a nanostring, usually they will require certain percentage of tumor. And then like the cost is definitely higher, the turnaround time is longer, but you will be able to get like information of multiple genes, like at the same time, instead of one at a time. So something like RT-PCR, you can imagine that like you don't really need a whole lot of tumor. It can even be used as MRD, and the turnaround time is a little bit less. So then it really depends on our need and what you want, what kind of information you need for your case, and then that can help you with the diagnosis or help the treatment. So that kind of conclude like the gene expression profile part, and then we have like a poll question. This is really just kind of like for people to do a mental exercise after a weekend in like Las Vegas. So then, which of the following methods cannot be used for evaluation of a gene expression? Okay, I'm seeing actually an arrow in the slide, so I think it probably there will be something. Actually, the answer is supposed to be can be used. So then later you're gonna see the answer was totally wrong. So then just bear with me, yeah. So I don't know if anybody's willing to share the answers, but the hint is that actually the right answers stick together. Actually, these two can be used actually for evaluation of a gene expression. You can see the title page is actually correct on this slide. So the real-time PCR and then like a quantitative RT-PCR and whole transcriptome analysis can be used for evaluation of gene expression. Single sequencing is usually used to evaluate DNA alterations and karyotyping for structure variants and also copy number changes. So that's actually for the gene expression profile part. And now we're gonna actually switch to a different topic. We're gonna talk about copy number alteration. So hopefully we can just continue. So again, we start with another case. This time our patient is a 39-year-old female presented with cervical lymphadenopathy. And the excisional biopsy showed a diffuse proliferation of medium and large size abnormal lymphoid cells. There were mitotic figures, and there were tangible body macrophages. There were like a starry sky appearance. I hope everyone can kind of tell where I'm going. And they are all positive for CD20. So just that, like, I think it is a certain diagnosis. Fisher for MYC rearrangement came back a negative. So, okay, for whatever it's worth. So now, because MYC is negative, there is another differential diagnosis that actually comes to mind. That's a high-grade B-cell lymphoma with 11q aberration by WHO classifications, or we call it diffuse large B-cell lymphoma with 11q aberration. That's by the ICC classification. That's just another demonstration how exciting it is to be a hematopathologist nowadays. So high-grade B-cell lymphoma or diffuse large B-cell lymphoma with 11q aberration morphologically or phenotypically can resemble Burkitt lymphoma or sometimes large B-cell lymphoma, but do not have the MYC rearrangement. So the 11q aberration in this group actually is characterized by proximal gains and then telomeric loss. So how do we identify this to even render this diagnosis? There are a couple things that we can do. So again, we start with our old friend, fluorescence in situ hybridization FISH. It is really a way to detect changes regarding a specific DNA sequence on a chromosome. So we designed a probe, target a specific region. So here is the sequence Y. And then usually this probe will be conjugated with a fluorochrome. So imagine you hybridize it to a slide. You get to see where that sequence is. This is, again, an oversimplified kind of illustration. And so we will be able to detect and localize the presence or absence of specific DNA sequences on chromosome. And this is actually sort of the way we think about a copy number alteration FISH probe. But we have a break-apart probe, we have fusion probe, those are different. But we are talking about a copy number alteration probe right now. So this is another way actually to detect the copy number changes. If you can see, this is microarray. So then microarray can be used to identify chromosome gains, loss, and a copy neutral loss of a heterozygosity, which is important because copy neutral loss of heterozygosity will not be detected by either FISH or by karyotyping. And this is something that you probably have heard a lot, like OncoScan, cytoscan, this is all this kind of a microarray. So how does it really work? If we look at the left side, again, I have to apologize. This is an oversimplified scenario again. Look at the left side, normal. Imagine we're looking at a normal cell, and we are using 3 SNP loci as an example. At every single SNP locus, we're gonna get a paternal allele and a maternal allele from the dad and from the mom. And so then you can see that like we have the AT and also like the CG array. Let's say that one is considered as A, the other one is considered as B. So your combination would be AB, AA, or BB. So the way to actually look at the copy number is we add up the intensity signal from the AT and then the CG together, and then divide it by the reference. So if you have a normal actually signal, it's gonna be 1. The ratio is gonna be 1. And then when you take a log2 ratio of it, it's gonna be 0. So that's why it stays at the baseline. But let's look at a normal cells on the right. Now we lose one of the allele. Now we only got things from dad. And then so instead of have AB, BB, AA, we only got ABA. So then looking at the intensity, now every single locus gives you half of the intensity. And when you divide it by the reference, it's gonna be 0.5. So when you actually take the log2 ratio, it's gonna be minus, and that's why it's actually below the baseline. So you can actually tell, this is kind of giving you a rough idea actually how like the copy number changes can be done through microarray. The technical sensitivity is actually about 20 to 25% actually for this array. So what can we see actually in this high-grade B-cell lymphoma or large B-cell lymphoma with 11q aberration? That's what we see. On the left, that's what you can potentially see with the microarray. You have a proximal gain at the area like 11q 2, 3, and then you have a telomeric loss at the 11q 2, 4. So then that's actually more or less the pattern you can see. Something is above actually the baseline, something is below the baseline. And then you can also use a FISH to identify it. So this time you will need help with multiple probes. So first we have 2 central probe for chromosome 11. And if you still have a 2 chromosome 11 centromere, you got 2 signals. That's why you have 2 signals right there for the centromere. And then we have a probe that targeting 11q23. That's usually the KMT2A. If you have a proximal gain at that region, you got multiple signals. That's why I'm showing 3 signals right there. And then you have your probe that targeting the telomeric actually region of the 11q. And then now you are actually seeing less signal if you have a telomeric loss. That's why I'm just actually showing it like 1 signal. So this is actually something you can potentially see when you use the fish to identify this. But some of the cases potentially can be missed by fish like assay. So then, some people will advocate that you should still probably consider like an oncoscan or cytoscan for this kind of cases. But fish does actually help identify a significant portion of the cases already, actually. So this is actually, again, a summary of some of the methods that you can potentially use to identify copy number changes. So first, we are going fancy. We're talking about whole genome, whole exome sequencing, right? And then those cases that in order to identify copy number changes, because we are actually using a pool sample, you really have to have a significant percentage of tumor cells for you to see that change, actually through whole genome sequencing or whole exome sequencing. But it gives you very good resolution, because after all, we are talking about sequencing down to the nucleotide base level. So then you could have a very nice resolution when you are talking about copy number changes. But it's expensive, and it actually takes a long time. But it also gives you the information of loss of heterozygosity. The second thing that you can consider is something like a targeted panel, or like the SNP array. Those things work somewhat kind of in middle. Like you probably do not need that high of a tumor, like percentage, and then most of the time they can give you loss of heterozygosity information as well. The resolution kind of depends, but when we talk about SNP array, it can potentially go down to like 100 kb. So it's not horrible. But if we talk about fish or karyotype, those are our old friends. It's very easily accessible, but they would not be able to give you the information about loss of heterozygosity. And then the turnaround time kind of vary, especially for karyotype. When you are relying on karyotype to detect copy number changes, that the resolution is not great. You are looking at a 5 to 10 MB. In the interest of time, I didn't really talk about optical genome mapping. That's something that you probably have heard a lot these days. That's another emergent technology. So that technology actually can go down, the resolution can go down to actually even 500 base pair to a 5 kb. So it had good resolution. And then the tumor percentage requirement maybe even a little bit better than the SNP array, but it requires fresh sample, because it actually does require ultra long kind of sample to do the assay. So that's actually something that I didn't really put it in the summary slide, but I would like to mention, because I guess you guys will probably hear it a lot kind of in the coming years. So it doesn't need a special kind of preparation, but then it does have its advantage and a disadvantage. So then actually it comes to our poll question. I would like to give people a little bit time to think about, but I think this one is really too easy for anybody. When it comes to the detection of a copy number alteration, the resolution of karyotyping is better than SNP arrays such as oncoscan. I feel like this is really kind of a giveaway, because we kept saying that karyotyping probably will not give us that good of resolution, right? So that the answer is actually false. So we kind of cover a little bit about the gene expression profile and also the copy number changes. And then now we're gonna switch gear and then talk a little bit about molecular assay that you can use to kind of monitor MRD, measurable residual disease. So again, we start with our patient. This time our patient is a 7-year-old boy diagnosed with B lymphoblastic leukemia lymphoma with ETV6-RUNS1 rearrangement 4 years ago. So despite that, we all hope this is actually a good prognostic marker. The kid will be fine. Unfortunately, he had multiple relapse and then status post chemotherapy for many times, and then had done target therapy, even including blinatumomab. So then now he's going for transplant. So then we got a request from our clinical team, tell me the MRD status of the kid. So we always heard about MRD. This concept was actually essentially non-existent when I was a fellow. So then I feel you can tell how old I am. And then so this is something we heard a lot, minimal residual disease. And then now the preferable name is actually measurable residual disease. So actually what it really means is number of tumor cells after treatment. So that's actually essentially what it means. So to measure the effectiveness of a treatment and to predict relapse is why we actually want to monitor MRD. So the number of tumor cells may not be detected by traditional methods such as morphology. So remember when I was a fellow, anything less than 5% blast is next case. But then now it's like, wow, there were a lot more assays to follow up. And the more sensitive a test is, the more effective it is to finding a small population of tumor cells among normal cells. And we have so many different kind of ways that we can look for measurable, like residual disease, but most commonly used one would be flow cytometry, quantitative RT-PCR, and next generation sequencing. And I just leave it as next generation sequencing, and we're gonna talk a little bit more about that. So we cannot talk about quantitative RT-PCR if we're talking about like molecular-based MRD assay, because this is the most historic one. Like this is the oldest and the most established methods. So why? Thinking about BCR-ABL that we have been doing for decades, like to measure like the residual disease, right? And then now you can easily find RT-PCR that was offered in reference lab to identify a lot different kind of fusions. PML-RARA, like RUNX1, RUNX1T1, your inversion 16. So the sensitivity of like the quantitative RT-PCR is usually 10 to the minus 2 to 10 to the minus 6. So then it also depends on the probe a little bit. How does it work? We already talked about the first part, like RT-PCR. How does the quantitative part work? So imagine that like we were talking about the intensity of the fluorescence signal is proportional to the amount of the final product that we have. So we decided we are gonna draw a line, a threshold. So whenever that fluorescence signal reaches that threshold, we call it CT value. That's called like the cycle of threshold, CT. And imagine if you have a lot of disease, it won't even take that many PCR cycles. You are gonna reach that threshold, a lot of fluorescence already. So then that's low CT. That usually means you have a lot of disease. If you have very little disease, it would take so many PCR cycles for you to actually even reach that threshold. That's why it's a high CT number. And then that means the patient actually have a lower disease volume. That's essentially how we report actually the RT-PCR. The second method that we're going to talk about is what we call high sensitivity sequencing for somatic mutation. So we can identify somatic mutation in any sort of a cancer. Can we just trace that mutation and see if there was still disease? Of course, but we cannot do it in a regular way. It has to be a high sensitivity actually sequencing. So what do we really mean by high sensitivity? It actually requires an error correction step. So high sensitivity sequencing for MRD detection requires the step of error correction to reliably identify mutations below the intrinsic error rate. That was just caused by PCR reaction or sequencing reaction. So that doesn't exist in the patient. Whatever I'm reporting to you is actually just an error by all the reactions. And then you don't want that because I'm gonna say the patient have a disease, but it's not. Actually, like we created it during this million different kind of like reactions. So then I want to talk about what is NGS, because we always just say NGS, but what is really NGS? NGS really just means next generation sequencing, and it's a massive parallel sequencing. It's really just a technology. We are talking about sequencing a lot of things all at the same time. So I'm using like the Illumina kind of like technology as an example right here. So imagine like the DNA fragment are hybridized to the flow cell surface, and each fragment is amplified into a colony clusters, as you can see kind of on the left. So going through cycles, you're gonna have this cluster growing bigger and bigger. So it's like a carpet. You are seeing all this cluster growing out of it. So it is very similar to Sanger sequencing, like what we learned. And every single cycle, you flux it in a different fluorochrome conjugated nucleotide. So then we take a picture. So now, because it's a huge cluster, you will be able to see the signal. Let's say this is a cycle. We see the red and we see the green, like we see the orange, we see the black. That actually corresponded to different nucleotide. So if the next cycle, I'm seeing a different combination. So in this case, I would just be able to say, hey, the cluster 1, actually the sequence should be TG. In cluster 2, it should be CC. Cluster 3, it should be AC. That's more or less actually how the next-generation sequencing was done. So I was talking about high sensitivity sequencing. How is it done? So essentially how we do it is we add a unique molecular identifier. So every single DNA fragment, in the very end, there is a unique molecular identifier added. So library amplification in the sequencing will result in duplicate DNA molecules, each labeled with the same UMI, unique molecular identifier. So now you can see original we only have 3 fragments there, but now you get couple with the green, couple with purple, couple with blue. That's after we added the green, purple, and then blue as unique molecular identifier. And then now they were all labeled with the same kind of color. So randomly accumulated sequencing arrows that actually were highlighted in orange color will only be present in only a subset of reads within the same color family, because they are just randomly happening during all these reactions. So they are not supposed to happen to 100% of these reads. However, so then when we do the analysis, we're just gonna discard all those reads, all those orange ones that did not show up in 100% of the reads. But the real mutation that's highlighted in black color, that G, actually will show up in all the green reads, because that's actually what our template was really showing. So for that, it's gonna survive the analysis and then be called as a mutation. So with this extra step, you will be able to identify a mutation that's actually a very low percentage, that's even below the error rate. So that's actually how we can potentially use a somatic mutation to track down a minimal residual disease or measurable residual disease. So I left that slide with just NGS because there were other methods that we can potentially use to identify MRD through NGS. And then that's something that you guys probably were all very familiar with, is to sequence the immunoglobulin and then the T cell receptor rearrangement for B and then T lymphoma. So high throughput sequencing of the hypervariable regions of immunoglobulin, we are talking about IgH, IgKalb, Ig lambda, and then T cell receptor, the TRB, TRG, can be used to measure the MRD in B and the T cell neoplasms. So this is how it works. Like the primers targeting different regions of V and J. This is our Genway textbook, the VDJ recombinations, and then they can be used to quantitatively evaluate the B cell and the T cell repertoire. So at Diagnoses, you are seeing a sample that was a very high percentage of tumor. So then you could actually identify that one sequence is associated with tumor. And then when the patient is post-treatment, the sample now have a very few tumor cells. We are looking for that specific VDJ recombination in that sample. So then like a high throughput kind of sequencing will allow us to find that dominant sequence present, absence, or the level. So that's pretty much just the principle behind this assay. However, there were definitely caveats for all these assays, just like what Dr. Furtado was mentioning. So then through the IgH and TR rearrangement, even though we identify them with the tumor, like some of the sequences may not be that unique. They can potentially actually occur as a part of a normal immune repertoire at a very low allele frequency. So maybe if we sample everybody in the room, like that sequence can actually just show up as a part of the normal B cell or T cell repertoire at a very low allele frequency. But that sequence also happens to be the sequence that's associated with a patient's tumor. So when the level becomes very low, there is always a concern if we are looking at just a background reactive B cell population or T cell population, or we are still looking at the B cell or T cell disease clone at a very low level. So in order to help with that, if we just kind of jump to the bottom, so then it's always advised like a laboratory should try to follow more than one dominant sequence. So if you see multiple sequences all at the same time, you will feel more confident that you are really looking at the disease, not potentially just something in the background. And then the other thing that actually potentially can cause issues in this assay would be we can see clonal evolution or any sort of things that happen during the progression. So then you may potentially lose that dominant sequence actually in the emergent clone, or like the dominant sequence actually got modified. So then that can potentially lead to a false negative results. So that's also something that we may have to kind of keep in mind. So I think many of you are familiar with this kind of a comparison, because our clinical colleague will always ask, like flow and MRD, and that's always something that we have to decide. Are we gonna go and send this out for a molecular-based kind of MRD assay? So, for flow, we get different kind of information. We can get immunophenotypic kind of findings. So then if the clinical colleagues want us to tell them the CD19, CD22 expression for target therapy, then you would not be able to offer them that through NGS-based MRD assay. But you will be able to do it actually with your flow assay, even though it's a small percentage of cells. But you could actually potentially see the repertoire, what's going on really for the whole B cells and the T cells, actually for the NGS-based MRD assay. And then, as you can tell, the turnaround time is very different. So then I guess if we got a phone call from our clinical colleagues, and then we would actually rush the case and give them the result if it's a flow. But for NGS, it does take actually 7 to 10 days turnaround time for a follow-up sample. So even if you really want to rush, it is very difficult to actually get the result within days. And the other thing that's important to note is that for BALL, if we take BALL as an example, both assays actually were pretty useful. So then I think based on some studies that have been published, 95% of the patients should have a aberrant immunophenotype to follow for MRD, and then 95% of the patient will be demonstrating a dominant clone that you can potentially follow as well. So it's not like one of the assays definitely superior to the other in that regard. And then the sensitivity is actually the biggest difference for many clinical colleagues. So then for the NGS MRD, we, generally speaking, I think you can go down to 10 to the minus 6. And then for flow, we are usually talking about 10 to the minus 4. And again, we are talking about different costs. The NGS MRD assay is, of course, a lot more expensive, and but again, the flow interpretation could be a little bit more on the subjective side, and then the NGS MRD interpretation probably will be a little bit more objective. The other thing that you guys may have heard is this allele-specific real-time quantitative PCR for B lymphoma or T lymphoma monitoring. So this is not something that's very common in the United States. Most of the literature was actually from Europe. So what they did is as follows. So first, you still do our regular capillary electrophoresis, a clonality assay, to determine if there was a clonal population or not. If you find a clonal population like whatever was shown in the second row, they did a Sanger sequencing of the sample. So then they identified this specific VDJ recombination. And for every single patient, they designed a specific primer just for that patient. So then that's actually what happened. They designed the primer for that patient. So when the patient comes back again for the follow-up sample, I just use that primer to do the RT-PCR. So this assay actually is not very standardized, because you can imagine for every single patient, you would have to design different primer, but the turnaround time will be a lot faster, as you can imagine, because when the patient comes back for follow-up, once you have your primer, it's actually just the turnaround time for RT-PCR. So this is sort of a comparison. Actually, the sensitivity for these two assays were somewhat similar. I think the biggest difference is really the standardization part. So that's the reason why it is actually not very commonly used actually in the States for a clinical purpose. And then the turnaround time, again, will be the biggest difference. If you are using something like a patient-specific kind of RT-PCR assay, usually it could be fast. And then compared to 7 to 10 days turnaround time for the NGS-based MRD. So, of course, by RT-PCR, you have potential the issues about non-specific binding and all this potential changes of the sequence, so then your primer no longer work. That still applies. So those are the things that you may have to consider. So this last slide actually is really highlighting why we get so many requests from our clinical colleagues to actually send a sample for molecular-based MRD. So this was a study that was published in Blood in 2015. So they were looking at kids with BALL that had to go through allo transplant. So we already know positive MRD is never a good thing before the transplant. So then they actually usually will predict a patient may have higher risk of relapse. But this study showed that many flow negative, like MRD flow negative patients still relapse. So then when they actually go back and look at the molecular-based MRD assay, they found out that if you have a molecular-based MRD being negative, the relapse risk and then like will be a lot lower for those kids, and then also like the survival would be better. So this is actually kind of, I think it's the landmark paper that demonstrated the need of molecular-based MRD with a higher sensitivity. So this paper also kind of talk about like, even post bone marrow transplant, if you use like MRD monitoring, it could help you identify those patients who probably need more timely and immediate intervention, even post transplant. So I think I'm just sharing this slide to kind of justify why sometimes we do actually spend big bucks on doing molecular MRD, especially in kids who is going for a transplant. That time point is very important for us to do a molecular MRD and to making sure that the MRD level is like, we have a higher sensitivity. So I guess this would be the poll question for this. We are talking about what methods can potentially be used for MRD evaluation. And then I think Dr. Furtado has given the answer away in the very beginning of like this talk. So then this is kind of an ultimate test if anybody kind of missed that first part. So then the option A will be RNA sequencing. Option B will be real-time quantitative PCR. Option C will be multicolor flow cytometry. Option D will be error-corrected deep sequencing. So there's one assay. Oh, actually, you know what? Did I just say that out loud? Never mind. So what methods can be actually used for MRD evaluation? Well, any takers? How about if anybody's willing to kind of join me and then raise your hand? Option A, any takers? Does people think like RNA sequencing can be used for MRD detection? I got none. How about B, real-time PCR? Yeah, I got a couple of hands, yes. I also want to raise my hand. How about multicolor flow cytometry? Yeah, I also think we can use that for MRD. How about error-corrected deep sequencing by tagging the individual DNA molecules with UMI? Yes. So I think like the answer would be B, C, D. So you guys probably can tell like when I was back in school, I always guess A whenever I don't know the answer. So that's actually pretty much like what we want to cover for the gene expression profile, copy number changes, MRD. So now I'm gonna turn the podium back to Dr. Furtado.
All right, so in this last session of the talk, we're going to go over DNA methylation profiling, which some of you have been hearing a lot about. So DNA methylation is a biological process by which a methyl group is added to the DNA molecule. And unlike the genetic alterations that we've been talking about so far, methylation is an epigenetic modification that changes the activity of the DNA segment without really changing the physical sequence of the DNA. And when methylation occurs at the gene promoter, it usually acts to repress the gene transcription. And methylation occurs during embryonic development, and it's very interesting because it's responsible for the tissue-specific gene expression patterns that develop. And interestingly, those methylation patterns that happen in tumor, they remain preserved. So even if you develop a tumor in a certain tissue, the original methylation pattern of the tissue of origin remains the same, and it becomes stable throughout the entire course of the disease, which really makes this marker a very dependable biomarker for tumor classification. So DNA methylation-based classification has been a very important change in the field of neuropathology because CNS tumors, they are highly prevalent, they have high mortality rate, and they are a very highly heterogeneous group of tumors that they have high some of them have high interobserver variability when using just histology alone. And there are therapeutic implications in being able to differentiate these tumor types. So the use of DNA methylation as a tumor diagnostic is started in neuropathology with this paper from a group in Heidelberg in Germany, in which they looked for how DNA methylation could actually perform in subdividing medulloblastomma subgroups. So at that time, we knew that medulloblastomas could be stratified into 4 subgroups based on transcriptional profiling, like in gene expression, which is demonstrated in the left box. And they show that by using high-density arrays, that the 4 transcriptional subgroups could be recapitulated using a methylation array, as you can see on the right. But it turns out that this is not a feature only of medulloblastoma, and it has been recognized that tumors with similar histology can actually be divided into molecularly and clinically distinct subgroups. And a good example are the CNS PNETs. So some of you may remember that a few years ago, we used to look at tumors and call them like the primitive neuroectodermal tumors. But it turns out that methylation has shown that this is not one homogeneous class of tumors, but there are different tumors such as BCOR-ITD, MN1 altered tumors, FOXR2 rearranged tumors, and even CIC rearranged tumors that can actually fall within that bin of PNET, so that doesn't exist anymore, and now we have more classes of tumor. So methylation array is really changing the way we look at the classification. And there has been a huge expansion in the brain tumor realm for defining tumor groups based on DNA methylation analysis. So in the new WHO that was recently released, I think a year or so ago, there are now 13 subgroups of medulloblastoma. There are 3, it is just examples of how much this has actually changed from what we knew based on histology and even some molecular, and now how granular this characterization is becoming. So we have 3 different ATRTs, we have over 6 groups of high-grade gliomas, and we have like 10 molecular groups of ependymoma. And it's interesting because for medulloblastoma, there is different in risk and outcome between the groups, and accurately stratifying the subependymomas, ependymomas, and myxopapillary ependymomas is also important because there are differences in treatment and prognosis. But a big landmark on methylation profiling for CNS tumor classification came out in 2018 with this paper that many of you may be familiar from the Heidelberg group in Germany. So they took examples of all brain tumor types that were in the 2016 WHO classification, and they methylated and they made this reference series that they use to train random forest, which is a supervised machine learning classifier. And using the supervised method is much more robust in the clinical setting than just using unsupervised methods such as the TCNE or some other approaches. So that's why this was so important, because now they not only generated a cohort that we can use to train our own classifiers, but they also demonstrate that the implementation in the clinical setting could be actually helpful for application. And currently, even though there are different ways to do methylation array testing, the most common, methylation testing in general, the most common is actually the methylation array testing, because this approach fits very well in our standard clinical workflow. It's compatible with FFP tissue testing. It has been the method used for development of all these reference series that we use for training our own classifiers. Doesn't require a lot of DNA, and compared to other methods such as whole genome bisulfite sequencing is much more, it's much less expensive. And the analysis of DNA methylation data in the clinical setting relies on supervised machine learning classifiers. So it's pretty much these algorithms, they learn from the data. We use reference data to train and teach the classifier what to recognize. And there are some specific features of the probes in the methylation array that are more relevant for the testing. And when you have a new sample that you run through the classifier, you are able to obtain a classification and also obtain a score that can actually give you, that you can use to develop a clinical thresholding for reporting. And over time, we evolve those classifiers by increasing the number of samples in the reference cohort, and we update the models as we get new samples. So at St. Jude, we've been using the methylation, we've been doing DNA methylation profiling for a few years now. We use the same reference cohort that Kapper had published from the 2016 data, but now we're updating our series. And we use a different method that we develop in-house, and we provide not only classification, but also we assess copy number alterations as well. This is a procedure that takes about 5 days, and one thing that's very important is really the pre-analytic. So tumor purity is an important factor that can affect the performance of these classifiers. Each lab will have their own threshold. For us, 70% tumor was the level that was effective for us, at least 70%. And the DNA input amount is also important. And the data, after it gets generated by the scanner, you can actually get we process that through a quality control and then a pipeline, and then we do the classification and copy number alteration. The way we report this, in addition to reporting the class, the tumor class that comes out of the classifier, we also report a calibrated score. And we develop a cutoff, a clinical threshold of 0.9, so anything above 0.9 gets reported, obviously in conjunction with the correlation of the clinical, the histopathology, and other molecular testing as well. And everything below 0.9 we consider not to be reliable. And we are doing that so then we can reject some predictions that may not be accurate, because anything that you put through a classifier is going to output an answer and a value, but you need to have a threshold like for any other qualitative assay in order to determine which answer you can trust. So DNA methylation profiling has many applications and has demonstrated great utility and impact on diagnosis, and it allows for more accurate classification of those tumors that are diagnostically challenging and cannot be resolved by histology alone. It can refine tumor subtyping and can provide some meaningful prognostic stratification for tumors that cannot be characterized at a higher level of granularity by other molecular methods such as medulloblastoma and ependymomas. And in some cases, DNA methylation profiling can also help triage further testing and can be helpful in tumors that don't have a lot of tissue, but then you can get one answer instead of having to be doing multiple tests as well. And here I'm just going to go over a few examples in which, how methylation profiling can be very helpful. So cases with some unusual presentation, right? Like this tumor in a gentleman who was 75 years old, but had choroid plexus tumor 15 years prior, and now have a mass in the spine. The pathologist at an outside institution was concerned about this being prostate cancer, but it turns out that one of the other hypotheses could be there could be a late metastasis of the original choroid plexus tumor. So just looking at the histology, it wasn't so easy to tease that out, but based on DNA methylation profiling, that diagnosis can actually be made, and it has a pretty big impact in how this would be treated. Another one, good application, is when you don't have any other alternative biomarker. You don't have another molecular test or IHC that can really help you tease out between different diagnoses. So this one, there was a conundrum between this being a pylomyxoid astrocytoma versus a myxopapillary ependymoma, and based on the DNA methylation classification, we were able to come up with the final diagnosis of myxopapillary ependymoma. And there are tumors in which sometimes you have the test for, but the tests don't work so well. So this was a tumor, a high-grade neoplasm in the brain that, based on the histology and the expression of WT1, you're thinking already, could that be a CIC? But the FISH was negative, which is not uncommon because there are some CIC fusions that are not detected by FISH. And we weren't able to obtain RNA to do RNA sequencing in this case. But luckily, DNA methylation profiling was helpful, and we had done a series of cases now in which shows that the DNA methylation profiling in CIC can actually be very helpful as a diagnostic approach with some caveats, which we won't have time to discuss. We can talk about that later. And unfortunately, because these tumors recur so much, 1 year later, the same patient came, we did the RNA sequencing, and then we were able to detect the fusion. So the DNA methylation profiling can be helpful when you don't have any other alternative for certain tumor types. And when you don't have a lot of tissue and you have tumors that can be difficult, like this one, in which you could think about like different differential diagnosis for this pineal mass, but having enough tissue to do all the workup very hard. So the DNA methylation profiling, we're able to classify this as a medulloblastoma group 4, and also we obtained copy number variant analysis, which was supportive of the diagnosis. And the molecular subtyping that I so very much talk about, because now we know how important it is to substratify medulloblastomas. Based on immunohistochemistry, we can get just so far saying that they are non-Wnt and non-SHH because you don't have the nuclear expression of beta-catenin and you don't have the expression of GAB1. And you can do FISH and detect the MYC amplification. But when we do methylation, we can not only obtain the same information in terms of the copy number because we can detect MYC amplification as well, but additional information because this is a genome-wide assessment of the copy number. So we can see when you have the isochromosome 17 with deletion of p53, which is actually pretty important in this group, and you can obtain the subclassification, which is very important for these patients. Particularly in our institution, because a couple years ago, we started a clinical trial in which we are substratifying patients, not only based on the clinical data, but also in methylation, DNA methylation findings. This is the first clinical trial that's using DNA methylation profiling for tumor stratification in medulloblastoma patients, infant patients. And for us, it's important not only to determine whether that's a sonic hedgehog activated, but we need to understand which subgroup of those are. So it's getting really granular because there are actually differences in the way these patients behave, and then we want to make sure that we give therapy accordingly and not overtreat or undertreat. And also important to understand if the patient has G3 because that's a much more a higher risk group. And sometimes, even if you don't obtain classification, you can obtain still very helpful information, such as in this case, in which the tumor did not obtain classification, but you notice that there were some loss around chromosome 6 that when we look, we can actually see closer that that was corresponding to the PLAGL1 gene, involving the PLAGL1 gene. So that drove us to do whole transcriptome sequencing, which identified the NWSR1 PLAGL1 fusion, which not only help refine the diagnosis, which is less descriptive, but also help us understand why the tumor wasn't classified, because this is a new tumor entity that wasn't in the reference series that was used to train the classifier. So that's one of the limitations of a supervised method. If you don't have that in your series, you won't be able to identify. So overall, DNA methylation profiling is really helpful because it can really improve the accuracy of histologic diagnosis. It can decrease the number of inconclusive calls, and it provides you meaningful prognostic subclassification and can even help guide some additional molecular testing. Currently, NCCN consider that DNA methylation profiling analysis is helpful, but they are not endorsing that as a first-line test unless the tissue is limited. And for the adult NCCN, they consider that to be an auxiliary method for classification of tumors. And this is because methylation has allowed us to have so much substratification of tumors at such a granular level that there isn't yet enough clinical correlation with all that complexity that's coming out there. So I'll just go real briefly over some of the limitations that I think are important to be known, both for when you're using the array for classification, and also for CNV analysis. And a lot of them have to do with technical artifacts. So as I mentioned before, the tumor purity is really important. So if you have tumors that are present in a big chunk of normal tissue, like in this case, and if you test the entire thing, you may end up getting a result like this. This was called as normal cerebellum, right? But then if you look, what really happened here is that the entire section was sent out for testing, and we know that our limit of detection is 70% tumor purity. So in this case, that was a false negative result, and that classification was just because there wasn't enough tumor purity. There was more cerebellum there than there was tumor. And that was actually supported by the low variant allele frequency of the whole exome sequencing and RNA sequencing that was done in this tumor. So it's very important to be aware when you're sending a test out or if you're testing your own institution to understand the technical limitations. Another thing is the DNA input. Our group and some other groups have shown that if you have less than 100 nanograms of DNA, it doesn't work very well. The array doesn't work very well. It's not very robust. Low quality DNA in our hands doesn't affect so much our ability to classify, but what happens is you notice that the CNV is much, like the plot of the CNV is super noisy because CNV is much less robust to the poor quality DNA. So you can get plot that's very not very helpful for the copy number variant analysis, even though in this case we're still able to detect the amplification of the C19 microRNA locus, which is one of the classic alterations in this tumor type. But it's always important to understand that tumor quality is always important if possible. So other things that can affect CNV analysis are actually biological. Sometimes you can have tumors and medulloblastomas that can happen a lot, in which the genome is so complex and you have almost a duplication of the entire genome. And this methylation array is not like the SNP array in which you can normalize to your normal level. So it's actually based on the intensity of the highest, the probe that has the highest fluorescence. So sometimes, like we have whole genome sequencing on the left and methylation on the right, and you notice that there is a complete discordance, right? Because those chromosomes that have a 2-copy gain are shown on the right as gain. The ones such as chromosome maybe 4, like 2 and 3, that only have 1-copy gain, they're shown as normal baseline. And then the chromosomes that are normal are actually the ones that have like showing the methylation array as loss. So this is not a perfect method for CNV measurement, but it's really helpful. And it's just important to understand the caveats in certain cases, in certain situations. And lastly, to detect focal intergenic deletion, this is not a method of choice because there isn't enough resolution, enough probes covering the genes at the gene level. So here is just an example of like a deletion in a retinoblastoma involving RB1 that only involved a few exons that wasn't detected by methylation array. So it's important to understand that. So if you have a negative result, you may not completely don't have a deletion. So I guess just some interpretive considerations real quickly. If your tumor is not represented in the reference series, you won't be able to classify. This is a supervised method. It's very similar to the same concept as other targeted methods in molecular, right? If you don't have probes to a certain gene, you won't be able to see it. And if you get classifier scores that are below your clinical threshold, it's likely that the result may not be correct, so it's hard to trust unless you really have other methods to support that. So this is the example that shows that very well. This was a case of a patient that had a pineal region teratoma, and the classifier called that as a papillary craniopharyngioma, but with a threshold below 0.9. So in cases like that, we just say that the methylation, the case wasn't reportable, and it turns out that it's correct not to report that as such, because based on additional workup, that turned out to be an adenocarcinoma arising from that germ cell tumor. So these machine learning methods, they're always going to try to find a match for something, and sometimes they find the best guess based on what they know. So it's very important to be strict about like how you determine your threshold and stick to it. And when you're ordering a test, make sure you understand if the intended use of your test falls within the tumors that the tests cover, because if it's not in the reference cohort, you won't be able to classify. Be aware of specimen requirements. Be aware of how to interpret values that are below or above threshold scores. And also know that this is not sometimes the only test, and you may need, obviously, to correlate with histopathology and sometimes do other tests as well. So I know we cover a lot, but I think the bottom line is that there is a lot of applications of molecular that we know that are well established and very helpful, and there are other applications coming out there. And I think the important is that even though they have a huge potential for a positive impact, it's always important to understand very well what the technique is able to do, so then you can choose your test accordingly, and you can interpret that in light of what you're really getting as a result. So thank you so much, really, for joining us. I think we probably, I'm not sure if we're over time, but we may have a minute or two for questions. Thank you.